So, ladies and gentlemen, welcome. This is Viren, and I'm here with Neha. We're both journal chests, social media editors, and we're excited every month to bring you an article that we do Journal Club on. And the idea is to learn the art behind the science and then consider how this changes what we know and how it can change our clinical practice. Today, we're talking about Alpha-1 antitrypsin deficiency in direct-to-consumer tests, right? People who get direct-to-consumer tests, and then they get genetic reports from it. So our authors today who are representing the author panel is Dr. Stoller and Dr. Ashenhurst. So starting off, me, I'm a PalmCrit guy out here in Syracuse, and I love working with my fellows and residents, so education is something that I absolutely am interested in, and that's why I do this. Neha, you want to talk about yourself?
Sure. I'm an assistant professor of neurology and neurosurgery, neurointensivist at Mount Sinai, New York. I'm a health services researcher and just about scratching the surface of implementation science. Happy to be here.
Awesome. And both of us do not have any conflicts. So we're going to introduce our authors and then our content liaison, Dr. Menino. So Dr. Ashenhurst, do you want to introduce yourself and tell us about your conflicts?
Sure. James Ashenhurst here in sunny San Francisco. It's a beautiful day today, although chilly. My background is actually in, I have a PhD in neuroscience, where I mostly studied addiction and behavior neuroscience. And then after a postdoc, I started work at 23andMe about 5 years ago, where I'm a scientist who leads the development of many of the direct-to-consumer reports, one of which is the subject of today's talk. And I am an employee and shareholder of 23andMe, so that's my disclosure of conflicts there. I'm very excited to share and talk more about this article.
Awesome. Dr. Stoller?
Well, good afternoon, everyone. My name is Jamie Stoller. I'm a pulmonary critical care doc at the Cleveland Clinic, and I serve as professor and chair of our Education Institute as well. I've had a longstanding interest in Alpha-1 antitrypsin deficiency, serve on the board of directors of the Alpha-1 Foundation, and have had a longstanding interest in Alpha-1 going back to being the co-principal investigator of the NHLBI registry, which goes back now many years. And I have a number of conflicts with regard to Alpha-1, including having served as a paid consultant at 23andMe on this particular body of work. So I'm delighted to be with you today and hand it back to you, Vera, please.
Awesome. Thank you for doing that. Dr. Menino, you want to tell us a little bit about yourself?
Yes, my name's Dave Menino. I'm a pulmonary physician. I'm a professor at the University of Kentucky, although I work part-time now. I'm also the medical director of the COPD Foundation. I was on the editorial board that accepted this paper into chest, and also like Dr. Stoller, although I'm not currently serving on the Alpha-1 board for years, I've had a long-standing interest in Alpha-1 antitrypsin deficiency, and actually chaired their medical and scientific advisory committee for years. So continue to be interested in this area.
Perfect. So now we have Alpha-1 powerhouses, and there's some learning to do. All right, so let's get started. Dr. Ashenhurst, starting with you. So how's the landscape, right, of the diagnosis of Alpha-1 antitrypsin deficiency? How is it evolving with the advent of direct-to-consumer testing?
I think actually that might be a better question for Dr. Stoller to answer, because he's more on the front lines in the clinic.
I like volleys off the bat. Let's do it.
Fair enough. I'll be happy to accept the serve. Thank you, James. So I think the backdrop here, and my pulmonary clinician colleagues will certainly recognize this, that Alpha-1, like many conditions, is heavily under-recognized. We know this from a variety of studies, not this particular study, but going back to the 80s in Sweden, when Sveger and colleagues did population-based screening with 200,000 newborns tested and found 127 individuals, as I recall, who were ZZ deficient. And yet when we look in every country in terms of the prevalence of diagnosed patients, it's far less than the estimated population prevalence. In the United States, it's estimated that of the 100,000 estimated Americans who have Alpha-1 antitrypsin deficiency, fewer than 10 to 15,000, 10 to 15% are recognized. So there's a large burden of unrecognized disease. And many of us, David and I and many other colleagues of ours interested in Alpha-1 have really, over the years, tried to advance a number of diagnostic strategies, including publishing guidelines and so on, to enhance detection.
I'm in the middle of a phone call. Just tell me what's the summary. Sorry.
And so this particular study emerged out of, again, tremendous interest in identifying an unrecognized population with Alpha-1, namely through direct-to-consumer testing. So it's one of a series of strategies in a diagnostic armamentarium, and as we'll discuss, an important one. I'll stop there.
As Viren is taking another call right now, we'll just extend what you said, Dr. Stoller, about this gap in diagnosis and this unrecognized need. So in this study, as you were designing the study, what were you anticipating that you're going to find? How much of that gap will direct-to-consumer testing be able to bridge?
It was very much an unknown because we knew that quite likely some people would arrive at the DTC product knowing that they had these risk alleles and already having a diagnosis. But being something that is under-recognized, there probably were going to be plenty of people who had pulmonary challenges, had COPD or other kinds of things like that. And a physician, maybe they didn't have known family history or something like that. So it would be a surprise for them to learn about their genotype and their corresponding risk through the test. So we really wanted to see how many people potentially newly came to understand this genetic risk, and then what did they do with this information? How many of them went on to share this information with an appropriate physician and then actually receive a diagnosis and start treatment or care or any kind of intervention they need? And also, would this initiate any kind of like cascade screening in their family? Would they tell family members, and would family members also get tested as a result? So that really was among our main kind of goals of understanding the impact of releasing this direct-to-consumer report to millions of people who've taken the test.
You know, I might annotate that as well. I completely agree with James. There are really 5 goals. One is to try to characterize the prevalence of Alpha-1 in this population, arguably the largest single sample ever described, almost 200,000 individuals, number one. Number two, albeit self-reported, what are the clinical features of these individuals? Number three, what was the diagnostic delay interval? We'll talk about that later, but how much time transpired between their self-reported first symptom and their first recognition of Alpha-1? There's a robust literature on this that antedates this study. And the question is, what are the findings here? And then the fourth and fifth, as James has so nicely stated, what are the managerial implications? What are the behavioral implications of learning that you have a genetic risk factor for a condition, for COPD and for liver disease, if you're a ZZ? And what are the reporting behaviors? Do you tell your doctor? Do you tell your family member? And again, albeit self-reported, these were things that have been relatively poorly understood in the literature. And this study provided just an amazing opportunity to at least get, as my mentor Alvin Feinstein would have said, to light a candle in the dark, maybe not to illuminate the issue definitively, but certainly to light a candle in the dark on these issues. Yeah.
Perfect. So with that, let's segue into this. So you guys talked about the priorities of the study. So how did you recruit participants into the study, number one, and who did you guys exclude? And then how were you left with your final sample?
Absolutely. So if people might not be familiar, that 23andMe also has a very large research platform. We have the world's largest database of genetic and phenotypic information. And most of what we do is run GWAS and do analyses like that. So this was kind of a unique project in that we're looking at kind of what people are doing with the information. But within the DTC product experience itself, you can opt in to participate in research, and about 80% of people do. And then there's like a little research tab on the website that you can click on. It's kind of a nearly infinite series of surveys or individual questions that people can answer if they'd like. Then that all gets aggregated and can be used for various kinds of research. So this study specifically, we developed a survey to try and capture what we were interested in understanding. and it was placed in the research tab so that people could just happen upon it. But we also wanted to enrich our sample with people who had an existing diagnosis of AATD. So if on another survey they had said that, yes, they have a history of that, they got up-targeted so they would be more likely to see it. And also people who had S or Z alleles, they were also up-targeted, so we can enrich the sample with that. And then this was also one instance where we used genotype-driven recruitment, where people who had not chosen to receive the health information through the product, but did opt in to receiving invitations to participate in research studies that might be relevant to them based on undisclosed genetic information. We also reached out to them as well to give them the opportunity to participate. And they were offered an upgrade to the full health service if they wanted that too, as part of compensation for participation. So it was in the research stream for almost 3 years collecting data. And then we finally got to a sample that seemed we had enough cases to dig into the data. And so in the second bubble, you see there how many people actually did participate in these different recruitment groups. And then finally, exclusions. We did exclude people who were younger than 18 or who had reported that they were older than 99. Some other sorts of conceptual inconsistencies, like saying that they were currently older or currently younger than a future age of diagnosis for some condition. The typical kind of outlier kinds of exclusions, like people who saying they had over 20 family members tested for AATD, just seems kind of unreasonable. So yeah, kind of conceptual things. And then that we arrive at that final sample of nearly 200,000.
Dr. Menino, now that you know, or you've heard, do you, as the content expert here, do you think this enriched sample potentially you would keep in mind for any reason as we go through the findings of the study, or any comments on the enrichment?
Well, yeah, I had a couple of comments, and of course, and understanding that the purpose behind this study, I thought this was a reasonable way to get people in. Although one of the, as an epidemiologist, I always hate excluding anybody. So it's always I'd much rather flag a person and then sort of at least have that data. But a question I had for James was, and as Jamie had mentioned, a study in Sweden that sort of looked at a bunch of newborns was able to get an estimate of prevalence of ZZ and MZ people in the population. Was there the capacity, and granted, and I understand that's not a part of this study, but does 23andMe have the capacity to somehow get that estimate of MZ and ZZ in the, now granted, this is a special population, the 23andMe tested population. Is that something that is, could be doable without jumping through a bunch of regulatory hoops, with the idea of somehow replicating what was done in Sweden? Yeah, because and to me that would be fascinating. Although I'm not even sure it's it's doable.
So we do have the genotype information for the entire population. So we could derive estimates using just the genotype information among consented people. And we do have a poster that we previously published that is referenced within the paper itself, which gives a more closer, unbiased estimate of the prevalence of the different genotypes within the population. And
what was that estimate?
I have to look at it again. Do you recall?
Not offhand. I can address though the question, David. This is clearly an enriched population. So
right.
When one looks at the Sveger study that you're alluding to, 200,000, then there was another study in this country, 108,000 newborns in Oregon. The prevalence estimates of ZZ type Alpha-1 in the Swedish study was 1 in 1,600, which is 0.02%. And in the American study, it was about 1 in 5,000. So we commonly split the difference and imagine that the prevalence of Alpha-1 is about 1 in 3,500. There are supportive estimates of those data as well. So with a prevalence of about 1 in 3,500, that's about 0.02%. The prevalence in this study of ZZ individuals, 349, is about 0.2%. So that's tenfold enriched compared to the estimated population prevalence, which in the abstract was quite identical to the American estimates of prevalence, by the way, in that 0.02%, roughly 1 in 3,500 was the takeaway from that, from the abstract that we reported prior to this study, also from the unbiased 23andMe data set. So the point is that these 200,000 individuals were enriched by virtue of various selection criteria. They're curious, they have a concern. Some of them had antecedent diagnoses of Alpha-1, and all of that culminates in a tenfold enrichment of the prevalence of the ZZ genotype in this population compared to a completely unbiased American population based on those population screening studies that we both alluded to, if that makes sense.
It's amazing, Dr. Stoller, you reached that conclusion with your mathematical genius. I, on the other hand, will take the benefit of being the moderator and having 4 screens in front of me. And the answer specifically to Dr. Menino's question is that the genotype frequency in the whole DTC database for Dr. Ashenhurst is 0.026% for ZZ and 0.129% for SZ. And I'm very sure this is very representative of general prevalence from previous studies. So even though enriched, if you look at the whole database, out of everybody who tests, the prevalences are the same. Frequencies.
Frequencies. Yeah. Let me clarify. I'm agreeing with you. The unbiased sample from the poster was 0.02%, and the prevalence here in this particular subset of that sample, that was millions of patients, by the way, in that poster presentation. These 200 or 195,000 patients are clearly selected on behaviors and are tenfold enriched compared to that population prevalence. I completely agree with you. I just wanted to put a fine point on that comment.
All right, so I will summarize table 1 for you, Dr. Ashenhurst and Dr. Stoller, just to provide context of what we're studying. So out of the 100, we're going to say about 200,000 patients, the sample size, 67% were women, 80% were white, so underrepresentation of African American or Asian patients, and which we've seen, and I think it's there for all of us to know and learn about. So I just want to acknowledge that 40% patients or people had smoked at least 100 cigarettes in their lifetime, and 8% are current smokers, and 3% reported any family history of Alpha-1 deficiency. So keeping this construct in mind, let's talk about the study results. So we can go through the major findings one by one. So let's talk about the genotype frequencies and prevalence. Dr. Ashenhurst, do you want to?
Sure. So yeah, what this table is trying to show is the different kinds of diagnoses that people with the different genotypes had received in their life. So, how many had a history of COPD diagnosis, how many had asthma, and how many had experienced bronchitis for more than 3 months. And one of the motivations behind this table too is to provide more information about the SZ genotype. Was when we were actually putting together the content for this DTC report, there weren't that many studies that had really good estimates about what the risks are for SZ individuals. And another thing to notice for the ZZ population in the cell for AATD diagnosed by a physician, only 50% of our sample at the time of the survey had an existing diagnosis of AATD. They very likely would qualify if they were tested. So this 50% population are the ones we really want to encourage to get this information into their medical system so they can close the gap and actually start receiving the care or treatment that they may need.
Yeah, Viren, this speaks to the unrecognized burden and perhaps the incremental effect of direct-to-consumer testing compared to the large population of unrecognized patients. I'll remind all of us that various guidelines, David and I were involved in the ATS-CRS guideline going back to 2003, and there are more recent ones published since then, that suggests that every patient with chronic obstructive pulmonary disease, every patient with fixed airflow obstruction post-bronchodilator on spirometry should undergo once in their lifetime a serum level and in most guidelines genotype for Alpha-1. And so, this just fits into that general reminder. I can tell you that practice, although guideline-based, rarely translates into clinical practice. And I'll tell you at the risk of great humility, some years ago in CHEST, we published a paper. Anil Jain is the first author. I'm the senior author. We looked at the frequency of testing at the Cleveland Clinic, not among lung doctors, but among all doctors, for patients who had fixed airflow obstruction on PFTs, what prevalence using our EMR were tested for Alpha-1. And then we deployed an EMR alert such that when the patient had fixed obstruction on PFTs, a big alert showed up, which was a single click to test for Alpha-1. Now the prevalence, and this is based on roughly 800 sets of 800 patients in each group before and after. Prior to the deployment of that alert, the prevalence of testing in patients who would have been eligible by guidelines for testing for Alpha-1 was merely 4%. And after the deployment in my own institution, that prevalence was now 15%. So it simply reminds us how refractory we as doctors are to embracing guideline-based practices. We see this in other contexts, right? Think about low stretch ventilation in ARDS. Many have, that paper was published 20 years ago, ARDSNet, and yet even today, we see patients not ventilated with 6 ml per kilogram ideal body weight, right? And so this is yet another example of the failure to embrace guideline-based practice. So I'll stop there.
Dr. Stoller, if I may just ask you a question about general behavior amongst the frontline providers. Why are we struggling to implement guidelines? What is it about our own behavior that prevents us from translating guidelines into practice?
Well, it's a wonderful question, Neha, and others have written about this. There's a classic paper by Cabana and Jama as to why doctors don't embrace this. It's in the 80s now. Some of it is a knowledge gap. Some of it is candidly arrogance. Some of it is impatience. Like I've tested 10 patients and didn't find one, and therefore I'm not testing anymore. We've actually studied the number needed to test in order to find a patient. Roughly 2% of patients with COPD on average would be expected, based on studies from Jack Lieberman and colleagues at the Sepulveda VA, about 2% of patients with COPD would be expected to have ZZ type Alpha-1. And so one would have to test on this number needed to treat analysis that we did years ago and published about 300 patients in order to find one, given the confidence intervals around those prevalence estimates. And so doctors characteristically will tell me, I tested my first 50, didn't find one, stopped, right? And there's also therapeutic nihilism. This is a paper by Groylich and colleagues, that folks think, gee, there's nothing to do about this genetic diagnosis. Why burden the patient with the psychological burden of knowing this? And that overlooks, of course, the obvious clinical interventions of counseling on smoking cessation, on smoking behavior, on occupational risk, because there are data cross-sectionally that Mayer and others, and we've published, that patients in dusty environments are more symptomatic if they have Alpha-1, as would be expected given the inflammatory burden to the lung, and recognizing that this is an autosomal codominant condition. So you're not only treating the patient in front of you, but conceivably his or her parents, siblings, and children who are at risk. So there is a strong impetus to make a diagnosis, notwithstanding the fact that there is currently available therapy, and even more excitingly, therapeutic interventions on the horizon that will change the landscape for treatment of this condition. So there are imperatives to make the diagnosis, and yet we somehow don't. And these diagnostic delay intervals, which is a metric of that, the duration of time between first symptom and first diagnosis, is persistently high. In this study, on average, it was about, you can see it was about 10 years. But in earlier studies, that number going back to the earliest study, one that we published in 95, was anywhere between 5 and 8 years. And those numbers persist to this day. 5 to 8 years is the patient journey between first symptom and first diagnosis of Alpha-1, which is a clarion call to the pulmonary community to have heightened sensitivity to this diagnosis. I'll stop there.
No, that's good, Dr. Stoller, because I was about to segue into the findings on diagnostic delay intervals. Just for our audiences, right, the way it's being defined is, Dr. Ashenhurst, how are we defining delay interval?
Yes, there are two survey questions. One was about at what age did you first start to experience symptoms? And then this, of course, was only asked of people who had a diagnosis. And then at what age did you receive that diagnosis formally? So we could take the difference between those two and get the number. There are people who are detected as having ATD or having genetic risk prior to the onset of any symptoms, maybe because there's known family histories. They actually did receive screening. And in that case, their delay was scored as 0.
Fair enough. So I think a few things to highlight in this table. One was the difference in the delay. If you already had a diagnosis prior from a physician versus you did not. So the two columns we're seeing here, there's the group who arrived at the direct-to-consumer product knowing they had a diagnosis of AATD. And then the column on the right is the individuals who most likely learned for the first time that they carried these risk alleles, took that information to a physician and received the diagnosis. So we wanted to understand, as we can see, the age of first symptoms is actually a statistically equivalent between the two groups. But for the group that was only recognized after the DTC product, there's actually quite a bit longer diagnostic delay. So I think it ends up being like 22 years. So for these individuals, there's a very, very long journey between first experiencing some symptoms and then finally understanding the cause. We don't have the anecdotal individual level information about exactly what these journeys were like, but this does suggest that for these individuals, it was a very, very long journey. And then to highlight, I think this was also interesting to me, is that the mean number of clinician contacts, 4.5. Mm-hmm. This is like the data from, like Dr. Stoller was saying, Dr. Menino, this is like data from sepsis, right? There's increasing awareness that even in the week or couple weeks leading up to sepsis, you already have those vital sign abnormalities, those early indicators that we just pester on. Same data with smoking cessation, right? So there's always an opportunity. This is in line with what you were mentioning about the guideline-based screening offerings, right? So clearly there's opportunity, and this, I think, adds to your point. What do you think, Dr. Menino?
Oh, yeah, absolutely. I think that's one of the frustrations, and this isn't. And there have been other studies out there that have shown similar, things, multiple asthma diagnoses and the like before and then person may have asthma in addition to having Alpha-1 deficiency and obstruction related to that. So, but I think sometimes clinicians may stop looking or may not you consider what else could potentially be going on, or may simply not be familiar, for all the reasons that Dr. Stoller had mentioned. And this is, and clearly there, although this is our field, if you sort of look through, different parts of medicine, you can, find analogous sort of, comparisons in other types of diseases, either genetic or non-genetic, where it often takes multiple events to get to the correct diagnosis.
I'll make two other points about this. First of all, Viren, this diagnostic delay interval, or the number of physicians seen, is quite identical to studies done in the 90s, right? Early on, we published a paper in which we showed that 44% of the patients who were diagnosed saw at least 3 physicians. That's almost 30 years ago. And so that number has not materially changed. We also know that diagnostic delay is associated with worsened clinical status at the time of initial diagnosis, a paper that my colleague Vic Tejwani and I published, in which the relationship between diagnostic delay and CAT score, SGRQ, and a trend towards worsened FEV1 with greater diagnostic delay. And the last point, to Neha's excellent point about why doctors aren't better at this, some people that are better at this than doctors are actually allied health providers. Respiratory therapists, for example, are better. And for example, when we empower respiratory therapists at the point of care testing in the PFT lab, and they're empowered to bring to the patient's opportunity a chance to be tested for Alpha-1, they actually find these patients. We, again, published studies. We've also just recently published a study in which we used MyChart, which is the patient-facing portal in Epic, in which when a doctor prescribes a LAMA-LABA, which is uniquely indicated for COPD, the patient gets a reminder that they could be tested at home confidentially through the Alpha-1 Foundation for Alpha-1. And in such a study, just recently published, that was the highest prevalence of finding heterozygotes of any strategy ever reported. Almost 15% of those individuals were heterozygotes. So, we need to be more creative in empowering colleagues to embrace diagnosis rather than depending on lung docs who are probably better at this than most, or primary care docs who are very busy taking care of other issues, hypercholesterolemia, hypertension, in 12-minute visits. I have great empathy for my primary care colleagues. I can't imagine how they have time to think about Alpha-1 faced with, managing hemoglobin A1Cs and hypercholesterolemia. So we just need to be better, more clever about strategies to enhance diagnosis of not only Alpha-1, but asthma and sepsis and everything else you talked about.
Such an excellent point about leveraging that team to ensure, particularly when we have diagnostic uncertainties or our clinical tools are not astute at picking up certain diagnoses, using the entire village that's supporting that patient and his family, including the patient and the family, in really helping us reach the diagnosis earlier so we can really bridge that gap in these diagnostic delays, particularly for a disease process that has therapies on the horizon, that has ways of risk factor modification, behavioral modifications, and implications for the entire family. Excellent points, Dr. Stoller. Viren?
I love this. I think you guys are setting me up for the not ethical, but I think ideological and applicative debate I want to have about screening shortly, but I want to get through the study findings first. So in that spirit, let's talk about result sharing, right? I don't know if anybody else there has done one of these tests. I haven't, but a lot of my friends have, and I know the results come and there's a bunch of stuff on there, right? You may know about, you may not know about it. Now, what do you do? So what did your sample patients do, Dr. Ashenhurst?
Yeah, so we stratified by different kind of levels of genetic risk into the different genotypes, and we asked questions of people who viewed the report. Who did you share this information with? And we asked about some specific categories of healthcare professionals, including genetic counselors, hepatologists, medical geneticists, nurse practitioners, pulmonologists, primary care physicians, etc. We really wanted to get a 10,000-foot view of who are they sharing this information with. And we did find, as we would hope, that people who had more genetic risk were more likely to share this information with a medical professional. And the most common categories were the primary care physician and pulmonologists. And then genetic counselor, unfortunately, is one of the lowest. And one thing we know is that the absolute number of genetic counselors in the United States is quite small compared to the potential need for interpreting this genetic information. But then for people who did not have the risk alleles, the MM, MS, and SS genotypes, very few of them did share this information with the different categories of physicians. This is also what we would expect and hope that people do, is not overrun the medical system with sharing results that are not actionable or are related to any risk. So really, as the people who are identified as being at risk, who are getting the appropriate, doing the appropriate thing and sharing results.
I will point out, just in the interest of time, it's still 50% with the ZZ did not share it with the healthcare providers?
Some of that is a timing thing too. We did ask one question about like, how long ago did you view your report? It's because it does take time. People can't just run out the door and make an appointment tomorrow. They might wait until their next annual physical or something like that. But that's true, yeah.
Let's talk about continuing further. Besides healthcare providers, who else did they share their results with?
Yeah, so there we asked about different relatives and who they might have shared the results with. And here we saw overall the prevalence of sharing behavior was higher than with engagement with the medical system, which is encouraging that people are actually discussing AATD with their family. And as we saw with healthcare professionals, people were far more likely to share this information if they had the risk alleles. And I think the most common category was with siblings, so that's good. And hopefully some of this resulted in additional testing of their relatives and identification of people who also are carrying that risk.
And then the mean number of family members who received testing themselves after the results.
Yeah, so we asked that question too, and there was a significant effect there, such that those with the ZZ genotype were the most likely to report multiple family members tested with an average of about 1.5.
This shows me like patient-driven, or I should say human-driven motivation to be better, right? This is, I think,
part of their health, right? That they're really trying to gain control of their own health, and they can drive health-changing behaviors potentially.
Yeah,
I mean, this gets to the concept of an activated patient, right? Which those of us who care for patients realize these are the ideal circumstance when the patient's well informed and the doctor is well informed. The outcomes, I would argue, are invariably better than when that relationship is asymmetric in either direction. Let's put it that way.
Great. So this segues well into then, do these people use any of this information to change health habits or to habits behaviorally? Do they make any changes? Do you want to talk about those results?
Sure. So the content of the direct-to-consumer report itself does highlight that smoking can exacerbate symptoms and that alcohol use can also exacerbate the liver problems that can also occur with this condition. And so among people who reported that they were current drinkers or current smokers, we then asked, did they reduce their alcohol consumption? Did they reduce how much they were smoking? And then we also asked a follow-up specifically, did the content of the report itself influence your decision to do so? And of course, I should mention being self-report and social desirability bias. We have to acknowledge that too as a limitation of these data. But what we do see, again, is a stratification by genotype where those who were told through the report content that they're at significant risk for this condition, they report that they took that to heart and decreased their alcohol consumption and decreased their tobacco use. So that was encouraging to see.
Yeah, I mean, the usual concerns are these are self-reported data, and all of us recognize as clinicians that patients' self-reported abstinence from smoking is sometimes discordant with actual behaviors or urine cotinine and so on when that's been checked. So this also aligns with an earlier study that our friend Charlie Strange and colleagues published in which they reported, I think, a prevalence, as I remember, of about 59% self-reported decreased smoking in response to the reported finding of Alpha-1. So these are certainly encouraging in terms of patient activation. But if we turn to limitations, these are, again, self-reported data. And so the actual behavioral change is yet to be known fully. An opportunity for further study. Yeah.
Fair enough. So let's talk about that. Dr. Menino, I'm going to pitch this to you while I check with Dr. Dangayach if she has questions coming in. But Dr. Menino, we've heard the results of the study. We understand how the data was collected. For you, what are the top two highest yield findings that you think we need to focus on as pulmonary critical care community? And then what are the two biggest limitations that you feel we need to keep in mind?
Well, I think to repeat what Jamie had mentioned, I think information is power, and getting information into the hands of patients that then sort of results in informed decision making is good. The flip side of that is information without the context for the information can sometimes cause anxiety in patients, particularly if they're prone to anxiety. And an analogy I'll use for that, and as I mentioned, I'm medical director of the COPD Foundation, so as part of my activities, I spend a lot of time looking at our social network that has patients who are get newly diagnosed with COPD, and over the past few months, we've gotten a lot of very scared people coming on saying, I had a CT scan for something else, and it says that I have emphysema on my CAT scan. I've stopped smoking, but I'm 42. I have young kids, and I went on the internet and says I'm going to be dead within 5 years. And basically, I spent a lot of time walking people back from the ledge, saying, "Well, I'm glad you stopped smoking. You've done the right thing. The finding of emphysema on a CAT scan can mean a lot of different things, and sometimes people have blebs or other things. And I think this is analogous in that you now have a bit of information in a person who is, and I imagine most of the participants in 23andMe, probably represent may not be representative of the U.S. population in terms of demographics. It's probably going to be lean towards a more educated person. I would guess, and I may be wrong on that, but that's always what I've assumed. So then people are going to have these questions and go on the internet and start, researching these things. And if they come back as MZ or ZZ, and particularly if they've had a smoking history, you may have some questions and anxiety associated with that. So I view that as being a potential downside, but you could also then sort of motivate people if they're sort of on the fence. And if they got 23andMe with the medical sort of, upgrade to sort of, get better informed on some of their, potential, factors for healthy aging, and this may get them there. So yeah, but information is always a two-edged sword, and I think that's something that we have to deal with, and we've seen it. And granted, we haven't sort of addressed the breast cancer gene, the BRCA genes here, but that's I suspect a lot of medical geneticist time, goes towards counseling for that type of stuff, which I know occurs before people get tested in a medical setting, but in 23andMe that may occur in the absence of that.
So this helps me set up for a question for, I suppose, Dr. Stoller, right? We briefly mentioned this before we got on air, and I do think there's something to be said about having this conversation, but screening tests, right? One of the tenets of screening, the ethical tenets of screening is that once you go looking for something and you find it, you need to have the ability to address it in a meaningful manner, right? That's all. I feel like that's one thing I remember from my community medicine rotations in India when they were teaching us about screening. It's good, go looking, that's great, but then you need to help people with it. You can't just say, okay, here you go. So this worries me a little bit, right? So you have now increased access. We're going to find information, in this case, Alpha-1 Antitrypsin Deficiency. So who handles it? Dr. Stoller, what is is it going to be primary care? How do you get access to that? 50% are already not reporting to physician. So what happens with people we find and then they never come in contact? What do we do? How do we handle this?
Well, that's a fabulous question and a key question, Viren, that you point out. And again, this is not a hypothetical. Both David Menino and I have cited the papers by Steger in the 80s where they screened 200,000 newborns in Sweden. And Thielen and colleagues published a number of series looking at the psychological impact of that diagnosis to newborns. One of the reasons that rightly or wrongly, newborn screening for Alpha-1 has not yet been embraced, although my personal prediction it will be with time, much like BRCA and other screens, along with CF and congenital hypothyroidism, which are part of, and phenylketonuria, which are part of standard newborn panels. The question is, what is the power of information? And my dear friend and colleague Sandy Sandhouse had a question in the chat about another unintended consequence, which is you give a patient this information and then there are potentially perverse clinical decisions that result, like treating patients with augmentation therapy when they don't have indications, when they neither have COPD nor have at-risk genotypes, when they're a heterozygote for the S allele or even the Z allele. We know from cross-sectional studies that SZ individuals who don't smoke are probably not at risk, nor are MZ individuals. And Sandy and I wrote a paper in CHEST years ago admonishing our colleagues from trying to prescribe very expensive augmentation therapy for patients that don't really qualify for its receipt based on not having risk. So the question emerges really at a societal level. If we are going to implement screening, to answer your question, there is, in my view, an obligation to link that information with informed sources that can help the patient navigate that. And in fairness, 23andMe provides text information that is carefully vetted and tries to direct people, including linking to resources like the Alpha-1 Foundation and so on. One could argue that we need more active connectedness between a screening test result and educated providers. Could be a genetic counselor, could be a well-informed primary care doc, certainly could be a lung doc, but even among lung doctors, there's a spectrum of understanding of Alpha-1. And so there really is this obligation for us as a society to connect screening with informed decision-making to help patients. Because surfing on the web can be a very scary, and as David pointed out, very scary and ill-advised strategy, which can drive both trauma as well as perverse clinical behaviors, right? So that's where that issue is from my point of view.
To that, I would add there's also a technical limitation, because wouldn't it be great if every healthcare system had completely interoperable electronic health records, and at a push of a button, all of your results from one service could go into your healthcare system and be available for your physician to see. So there's technical limitations too to like making that access happen and transferring the information appropriately.
And James, if that wasn't problematic enough, the interoperability of different kinds of electronic health records with wearables, with direct-to-consumer testing, not making that available within the body of the electronic health record, it becomes very, very complex. So while we want our patients and their healthcare teams to be well-informed, a little bit of information can be a dangerous thing when it's put out of context and when it's fragmented through different through direct-to-consumer testing, not making it to the EHR, and different EHRs not talking to each other. So I think this study highlights a very important thing that I wonder what all three of you will share with our viewers. What does this mean for direct-to-consumer testing moving forward? Should patients and families go ahead and continue the direct-to-consumer testing, or should there be more thoughtful utilization of direct-to-consumer testing, and what could that look like for our patients and families at large?
We could start with Dr. Menino.
Well, I think the toothpaste is out of the holder on this one. It's happened. It's out there. And I think the question it gets back to what Jamie had said. What do we do with it in terms of having well-informed patients and ensuring that that the best information for them is out there. So much what I mentioned with it now, everybody gets a CT scan if they go to the ER with chest pain or things, and there's lots of information that then sort of emanates from that potentially that can cause anxiety, additional levels of anxiety in patients if they're already prone to anxiety to begin with. So I think and this is out there. It's and like other advances in medical technology, I think we just have to adapt with it. And I think we'll see similar things, with the information coming in from wearables that now, gosh, I may have AFib, and if, what do you do with that? And in my little blood pressure monitor will say, oh, your heart might be a little irregular, even though I know I don't have AFib. But and you start getting this sort of plethora of information, and I think what we do with it, both as clinicians and to avoid that information overload, that we had sort of talked about earlier. I'm not sure that answers the question, but it's there, and it's just going to be one of the other things that we as clinicians deal with.
And to that, I would add, it's probably most likely that the patients that you see that are having some anxiety or misunderstanding, that's the population that is coming to you for more information. All the people who got it, who took the appropriate action, they're not coming into the office. They're doing what they should be doing. So there is a good chunk of people who are doing that as well. But yeah, I think over time, I think the medical community will get used to people having this sort of information. And we do have to remember that in the history of at-home testing, at-home pregnancy tests were controversial back in the day. People were worried that women would not be able to handle that information on their own, but obviously they can. So I think slowly society and the medical practice will change so that people will have more integrated care, access to this information as the price continues to fall. It just makes sense to have this in your medical file in other areas too, like pharmacogenetics and things like that, to really have more personalized medicine and care. So it's really about connecting the dots and helping meet people where they are.
And I have to say, I agree with that completely. As David said, the horse is out of the barn, and people are availing themselves in the millions. And so I don't think that we would revert to a sort of an ostrich syndrome, which is to pretend that we don't know information. This is a clarion call to enhance the interoperability of the EMR and the connectivity between screening and clinical advice. And we are absolutely getting better at this, by all means. We are slowly improving with time. There's plenty of opportunity to get yet better, without a doubt. But I think this is the right direction on balance. Like any clinical intervention, we have to balance risks and benefits. And my own view of this is that the net vector is in favor of having information then well interpreted and counseled. Absolutely.
Awesome. Dr. Dangayach, just as we're about to sort of close up, wrap up, do we have any pending questions from the audience that we could address?
No, I think we got a wonderful question already answered by Dr. Stoller. So I don't see any other pending questions in our chat or in the Q&A right now.
Perfect. So just to summarize, to close out, direct-to-consumer testing is going to become more commonplace, not just for Alpha-1 antitrypsin deficiency, but number of disorders. Two, I think there's clear evidence that people respond to this. And like Dr. Stoller said, it's patient activation. So I think there's clearly evidence that this is helpful across different sort of spectra, from awareness all the way to seeking care to finding about diagnosis. Gaps with screening, like we discussed, obviously the system needs to catch up and build capacity, but the answer cannot be, let's wait while we build the capacity. I think progress is happening, and I think as a medical system, we're going to have to keep up. So I really thought that when we picked this article to highlight this, it's a very coming of age article. Here we are. And that was the reason for picking this up, because in my practice, what do we do? So I think maybe as a team, we can address this together with our patients and learn from this and, build a better future for medicine, right? Awesome.
Yes,
absolutely.
Lovely. Thank you, Dr. Menino, Dr. Ashenhurst, Dr. Stoller, and Dr. Dangayach, as always. And you guys have a good day, okay?
Thank you very much for moderating.
This was fun. Thanks.
Thank you so much.
Flattered to be asked. Total pleasure to join you. Thank you so much.
Thanks.
Absolutely.
Take care, guys.